surgical outcomes in monoocular elevation deficiency.
Good afternoon, everyone. So I'll be talking about surgical outcomes in monoocular elevation deficiency. It's a case series. Introduction. Monoocular elevation deficiency, also known as double elevator palsy, is a rare ocular motility disorder. It is characterized by a unilateral defective upgaze associated with ipsilateral ptosis. The unilateral impaired gaze can be caused by due to the inferior rectus restriction or due to the superior rectus palsy or due to supranuclear disorders. The causes can be congenital or acquired. Causes of acquired could be trauma, cerebrovascular disease, sarcoidosis, syphilis, midbrain tumors. So the aim of my study was to evaluate the surgical outcomes in patients with monoocular elevation deficiency. Objectives to evaluate the outcomes of surgical procedures in patients with monoocular elevation deficiency, to analyze the functional cosmetics improvement post-surgery, to assess post-operative complications and long-term stability. So it is a retrospective case series. Sample size was 6. Inclusion criteria were all the patients diagnosed with monoocular elevation deficiency who underwent surgical correction, and exclusion criteria was patients with previous establishment surgery or neurological involvement. Pre-operative evaluation, complete ophthalmic examination was done, including the anterior and the posterior segment, with the ocular motility charting, Prince bar cover test, Wells phenomena was checked, force junction test and force generation test was checked, diplopia assessment was done. This is one of the patient's pre-operative picture. First one showing the left eye with the monoocular elevation deficiency with the ptosis and there's hypotropia. Other one is the 9-gaze photograph. There is limitation of the up gaze in all the adduction, abduction in the primary position above the midline. So result was in total 6 patients, 4 are males and 2 are females. Age range I included was between 8 to 32 years. Right eye was 4 and left was 2. Pre-operative hypertropia was 20 to 35 prism diopters. A mean of 28 prism diopters were noted. The procedures which are performed are the NAPS procedure in 3 cases. Modified NAPS with inferior rectus recession was performed in 2 cases, and isolated inferior rectus recession was done in 1 case. Post-operative outcomes, hypertropia was reduced to less than 5 prism diopters in 5 out of 6 patients, 83%. Elevation was improved by 2 to 3 grades in 4 patients. Diplopia resolved in the 5 patients, and cosmetic improvement was noted in all the cases. Complication, mild residual limitation was seen in the 1 patient. No overcorrection or anterior segment ischemia was observed. This is a graph showing the pre and post-operative hypertropia which was corrected. It was less than equal to 5 prism diopters post-operatively in the most of the patients. This is the improvement in the elevation in the post-operative period. Discussion. NAPS and modified NAPS procedures are effective in improving elevation and alignment. Inferior rectus recession needed in restrictive cases where the force junction test was positive. Early intervention prevents amblyopia in pediatric patients. Limitations of my study was it was a small sample size. It is a retrospective study design with a short follow-up. Conclusion. Surgery for monoocular elevation deficiency provides good functional and cosmetic outcomes. Choice of procedure should be individualized based on etiology, where it is restrictive or paratic type. Long-term follow-up is essential to assess the stability. Thank you.
Cool. Just one. Can you explain a little bit what kind of modified NAPS was there? I mean, the details of it.
Sir, in modified nerves, we don't take the full horizontal muscle, we take a strip of it, then we transpose it with the superior rectus.
Right. And did you have to do the augmentation also in any of the cases? The Foster's augmentation, that you apply a non-absorbable suture almost 8 millimeter from the insertion of the superior rectus?
No, sir.
No. Right.
You have a scoring sheet, sir?
Yes, sure, sir. So,
No, you are also supposed to judge. Convener is allowed. Any more questions, sir?
no, not.
Okay.
Thank you.
Thank you, sir.
Long-term study of retinopathy of prematurity sequelae at a single center in North India.
Good afternoon, everyone. My topic for the day is ROP over the decades. So we did a long-term follow-up study of retinopathy of prematurity patients at a single center in North India. The aim of our study was to study the sequelae after ROP regression with long-term follow-up and analysis. It was a retrospective and observational study which had 65 patients who were diagnosed and treated at the single center and the time period ranging from 2003 till January 2025.
Kindly stop. I'm not able to see the whole slide. Previous slide. Next slide. Yeah, now it's fine. Kindly reset the timer, please. Reset the timer to 5 minutes.
Yeah.
So the best corrected visual acuity, refractive error with cycloplegic retinoscopy and fundus examination was noted at every follow-up visit, and the stage and severity of ROP was classified according to the ICROP, that is the International Classification of ROP guidelines. The exclusion criteria of the study being the follow-up for less than 1 year, or the patient had stage 4 or stage 5 where there was urgent need of surgery and the patient was referred accordingly. So our results showed that out of the total, there were 35% with type 1 requiring urgent treatment and type 2 ROP in about 64% patients, which were observed subsequently till the disease was regressed and then later on. So out of those who needed treatment, the 23 that needed treatment, 2 got anti-VEGF injections, 19 underwent PRP laser and 2 was cryo. So this cryo was back in 2003-2004. The rest 42 patients had spontaneous regression. The median follow-up was for 3 years, the range being 1 to 20 years. So on analysis, the most common outcome was refractive error, followed by amblyopia, strabismus and nystagmus in one patient. So we also studied the correlation between the best corrected visual acuity and the birth weight, BCVA and the gestation age, BCVA and the comparison with the stage of ROP at the time of treatment, and the comparison of best corrected visual acuity in eyes those received treatment versus those that underwent spontaneous regression. Since there were only 2 who underwent anti-VEGF, so this data was excluded from the statistical analysis as the number was very small. So on correlation with birth weight and BCVA, as the previous studies have proved, the lower birth weight is associated with a poor visual outcome, which was less than 6/18 in our study, and the gestation age, so the higher the gestation age, the better the ultimate BCVA outcome. And correlation of the stage of ROP and the BCVA, so the severity of ROP has a negative correlation with the long-term BCVA. Initial stage is not a very good predictor because of the variability in the outcome. Stage and zone of ROP in patients have a significant effect on myopic progression as well, especially with severe disease resulting in a very fast myopic progression. That is high myopia and a very short duration, so the initially 1 to 2 years of life. Now comparison of BCVA at last visit in eyes post ROP treatment versus those with spontaneous regression. So 73% of eyes had achieved 6/12 or better vision. 27% has vision less than 6/18 or worse in laser treated patients. So multiple linear regression analysis revealed that better visual acuity significantly correlated with less severe myopia. Significant myopia was observed in those who had treatment, and out of the laser treated, 70% had myopia, and anisometropia was seen in 17% only. There was no significant association seen as such for strabismus patients. So coming to our discussion, the refractive disorder, they are the key factors when talking about visual outcome in patients with regressed ROP. And long-term outcomes of a study is, it cannot be concluded that laser plays a causative role. However, as myopia is related to scleral weakening, other factors are also should be taken into account, including anomalies of the corneal diameter, the curvature, anterior chamber depth, lens power, and axial length. Laser definitely causes disturbed ocular growth in infants, also due to the other systemic factors as well. Anisometropia also occurs in regressed IROP, mostly due to, as proved by theory, that asymmetry in the final peripheral retinal fibrosis can lead more significantly to anisometropia. So to conclude, refractive errors, they cause permanent visual impairment, even if cases having a stable retina status. So delaying in detection and adequate management of these refractive errors can eventually lead to amblyopia. The results of our study showed higher prevalence of refractive errors in ROP treated eyes, and prematurity along with physiological disruption caused by treatment modalities in the growing stage affects the final outcome. This is one of our patients who underwent cryo in 2003. On his last visit, this fundus photograph was taken. He has a BCVA of 6.9 in both eyes, but he has a very high refractive power. He has a high myop with -9. So the limitations of our study was that we had not taken into account the analysis of the retinal structure as being down with newer modalities like OCT. And also there was no comparison of axial lengths on subsequent visits. The patients who underwent surgery were excluded from the study. It is a small sample size of 65 patients, and detailed analysis of number of laser shots, the energy used was not done, and the control group of full-term babies was not there to compare. Thank you.
So, excellent study. Dr. Jasneet, now coming to the sequelae. So, you are talking about the progressive myopia and strabismus. What about amblyopia? Because they are also commonly seen as a sequelae in these ROP patients.
Sir, amblyopia was the second most common sequelae in our set of patients.
Did you mention in any of?
Yes.
Okay.
I mentioned it in my slide. The 70% was refractive error, second was strabismus, and there was in the refractive error group, subsequently there were 24% who had amblyopia.
Dr. Bharat, any question?
So the PPT is closed, but it was in retrospective observational study. So the
यहाँ से press
So some kids had spontaneous resolution, some had laser. So did you actually wait for spontaneous resolution, or what? Because I don't understand, which subset of kids have you chosen? Are you choosing
All were regressed ROP cases?
all the regressed ROP cases, and then we further studied the comparison between the two, that those who underwent laser and those who did not undergo laser, and the
So what was
comparison
the
of-
age? What was the age group of kids which you chose?
Sir, it was a follow-up study, so we followed them up.
No, so what was the age? Means range, there must be some range, no? This is what sir is asking.
See, if you are following up, it is not retrospective, it is prospective. If you are following them up, that
Sir,
means you are starting from
it
one
is a
point.
retrospective data. The data
That is
started
what
from
confused.
2003.
Yeah.
The study the data collection started from 2003, and we collected the data of the patients who followed up at the center up till
So
January.
that means it is not retrospective anymore. Na? From 2003 it became a prospective study.
You mean to say they were treated for ROP, right? And later on followed in their childhood. This is what you are trying to say?
Yes.
Yeah.
So what was the age group? This is what we are asking, no?
So the
Means
average
5 to 12, whatever, some range?
3 to 20.
3 to 20.
Actually 1 to 20, the median was 3. So
Okay.
less than 1 year
But,
follow-up we did not take into account. So
If you are
post 1
following
year.
up for 20 years, I don't think it should be retrospective. It is a prospective observational studies. It is prospective non-interventional based. Yeah. Thank you.
Thank you, sir.
Thank you, Dr. Jasneet.
Any questions, sir?
No, sir, not my talk. So the treatment outcome of ROP infants with zone 1 and zone 2 posterior disease in North India.
Thank you, sir. So today my topic is the study that we have done retrospectively by observing our case series.
Slides, please. Slides.
Yes.
Yeah.
So this is a retrospective study which we have done by studying the case sheets of babies who were treated for ROP in our center. So just a background, that ROP, as we know, is a sight-threatening, treatable and partially preventable cause of childhood blindness. It's a microvasculopathy of retina arising due to VGF overdrive. It is multifactorial, but prematurity, low birth weight and unmonitored oxygen supply are the most important factors. And why did we need to do this study was because we were observing a very high number of ROP babies, and because India, like other developing nations, is currently undergoing a third epidemic of ROP, and we lead the world in premature deliveries. A wide variation of poor quality neonatal services adds fuel to the fire, adds more number of ROP babies, and lack of adequately trained manpower who can screen these babies adds more numbers. Illiteracy and financial difficulties of parents add to the low rates of treatment. So before I go again to the study, I'll have to tell you how did the background, the classification. ICROP 3's revised edition, third is now currently being followed. It divides the eye into 3 zones, zone 1, 2, 3 for the disease. Zone 1 is the distance between disc and double the distance between disc and fovea. Zone 2 is the rest of the circle touching the nasal retina, and the temporal crescent shape is the zone 3. So this present study's aim was to analyze the outcomes of all ROP babies treated by me between 2017 and mid-25. Inclusion criteria was only the babies who were in zone 1 and 2 posterior ROP were taken, and only babies who had completed the follow-up, they were taken into account. What do we mean by completion of treatment was that the disease must have been declared regressed completely or progressed to warrant referral for surgery. So the treatment modalities used in the present studies were laser retinopexy of the avascular retina. However, a little tweaking to the early treatment ROP guidelines was done, and we added 2 to 3 rows of posterior to the ridge laser. A 532 nanometer green laser was used. In different centers, different brands were used. I have no financial interest in any brand. For intravitreal injections, again, various kinds of anti-VEGF injections were used, ranging from bevacizumab to aflibercept. For intravitreal injections, 0.025 cc, that is half the adult dose, was used 1 millimeter from the limbus with a 32 gauge needle on 1 cc syringe. Topical anesthesia was used, and eye was dilated and opened with Alfonso Pediatric speculum. Most of the procedures were done in OR under a microscope, and rarely some in NICU for sick babies. So total number of infants treated were 266, which forms in this study for zone 1 and 2 posterior disease, which forms 48% of the total babies treated. Rest were zone 2A and zone 3. Few of the babies lost to follow-up after treatment, few expired, so we were remaining with 236 babies for statistical analysis, out of which 81 were females and 155 were male babies. This is the zone and stage distribution. Most of the babies are in zone 2B, but however, in our study, large number of babies are also in zone 1, which is about 44%. And again, this subgroup has a very large number of AROP babies, which is approximately 30%. This is a very different cohort from other published studies. Mean gestation age was 29 weeks. However, the babies who were bigger, they added to the, contributed to the mean gestation age being higher, because the minimum GA was also 24. Birth weight distribution is here. It ranged from 650 to 2,700 grams. Mean was 1265 grams. Out of 116 babies who were given intravitreal injection, 77 still needed to be followed up with laser, which is 66%, which shows that injection is not a quick fix solution, and majority of the mainstay of the treatment was still laser. In the distribution of drugs used, there is approximately same number in which bevacizumab and ranibizumab, the regional research molecule, Eccentrix or Lucentis as it used to be called, was used. Ranibizumab's biosimilars were used in 44 babies, and in few babies 10 aflibercept was used. We saw that babies who were given Avastin or bevacizumab, 60% did not require laser, as other studies have also established that Avastin is the best drug to be used in ROP. These are the outcomes of zone 1 and 2 posterior disease. Most of the subgroups we have been able to achieve regression in 100% of the babies. However, in AP-ROP in zone 1, which is the most aggressive form of ROP, 5 babies had progression and had to be referred, and 1 each in stage 3, zone 1 and 2P had to be referred. Stage 4, all 6 babies were just lasered in order to prepare them for surgery, and they were referred to higher center for surgery. However, this study also shows that if your screening and treatment is adequate, very small number of babies really reach stage 4. And this is analysis of stage 4, that 4 out of 6 babies are from NICUs where no screening was being done, and it is a myth that stage 4 would be seen only in very small babies, because here only one baby was less than 30 weeks of gestation and only one less than 1000 grams of birth weight. So conclusion is that AROP and hybrid ROP is seen commonly in India. It's a cohort quite different from early treatment ROP guidelines. Like India specific screening guidelines, we need our own treatment guidelines also, and with a little modification in ET-ROP guidelines, we can really give very, very good results, 96% in our series. And the take-home message is that strictly implemented screening followed by timely treatment can drastically decrease surgery requiring stages of ROP, and excellent anatomic outcomes can be achieved even in aggressive forms of ROP, and intravitreal injections are not a quick fix solution. Thank you, sir.
So a good study, Dr. Ajay Kapoor sir. So as you are saying that this AROP and this hybrid ROP is different from the international data. If you are
No, sir. Aggressive ROP, AROP also forms a part of the ICROP3 classification, but most of the studies which are being published in that, the number of AROP babies is less. Since I practice in hinterlands, where in tier 3 towns and cities, there the quality of neonatal services is poor, and AROP and hybrid ROP are all pointers towards poor neonatal.
so what recommendations you have from your study so that we can incorporate in Indian this classification?
The recommendations based on this study are that even if you have aggressive forms of ROP, it can be very well managed if timely treatment can be given to the babies. And secondly, we need to talk to the pediatricians, to the neonatal specialists to reduce this AROP. Because not in every center treatment would be adequate or would be done timely. So then these babies would progress, because as also seen in my study that AROP in zone 1, 5 babies progressed. We don't even want those 5 babies progressing to treatment, surgery requiring stage. That's it.
Thank you. Any questions, sir?
No, sir. Excellent. Thank you, Dr. Ajay. So next I call upon Dr. Amod Vajpayee, microphthalmia and leukocoria.
Good afternoon to the panel, my seniors, colleagues. Today I would like to present a case of
Slides,
PHPV
please.
with microphthalmia and leukocoria. First we'll begin with the introduction. PHPV, now currently known as persistent fetal vasculature, is an uncommon congenital anomaly. It results from the incomplete regression of the primary vitreous and the hyaloid vascular system. The epidemiology on the current incidence and prevalence of PHPV is unclear. However, the literature available shows that remnants of any sort are currently in the prevalence of 0.35 in screened neonates. However, clinically significant PHPV is much more rarer. Classification: PHPV can broadly be classified into anterior, posterior and combined types. The anterior variant is usually associated with microphthalmos, cataract, shallow anterior chamber and glaucoma, whereas the posterior variant involves the vitreous, the retina and the optic nerve. Clinical significance: PHPV is a key differential for leukocoria, often mistaken for retinoblastoma. Early recognition and intervention are essential for visual rehabilitation and prevention of development of amblyopia. Chief complaint: the parents brought a one-day-old baby to the emergency with complaints of a small palpebral fissure in the right eye. History of present illness: the neonate was aged 1 day. He underwent full-term vaginal delivery, uneventful antenatal and perinatal history. Apgar scores, birth weight was normal. There was no family history of ocular disorders. The parents were non-consanguineous. There was no drug allergies and there was no history of exposure of any sort of toxin during pregnancy. Examination findings: On examination findings, it was seen that the lid had a decreased palpebral aperture with entropion. Cornea showed multiple fine abrasions that were fluorescent positive. Pupil showed leukocoria. The anterior chamber was shallow. However, IOP and fundus could not be assessed because of visualization and media opacity. This was the right eye and the left eye. There were no syndromic associations and no systemic congenital anomalies. Investigations done. The primary investigation that the patient was advised was B-scan, for which he underwent B-scan of the right eye. Shallow anterior chamber was seen measuring 0.3 millimeters. An axial length of 9 millimeter was seen. There was cataractus change along with an echogenic band measuring 5.2 millimeter extending from the posterior surface of the lens to the posterior part of the globe. Central vascularity was seen on color Doppler imaging. Most importantly, no calcification was seen within the band of the tissue. Evidence of PHPV with a persistent vascular stalk extending from the optic nerve head to the posterior lens capsule. Along with this, there was no retinal detachment or any optic nerve involvement. Left eye was normal. With all this in mind, diagnosis of right eye persistent fetal vasculature, unilateral combined type associated with microphthalmos, cataract, entropion, and corneal degeneration was made. Management. The patient was referred to a higher center for surgical management consisting of cataract extraction with PPV and prevention of amblyopia. Due to the multiple abrasions of the cornea, the patient was advised lubricating drops which are preservative free, 1 drop 4 times daily in the right eye. The patient was also advised eye drop tobramycin, and a pediatrician opinion was taken to rule out any syndromic associations. Surgery was deferred locally due to age and need for specialized pediatric vitreoretinal setup. PHPV is typically unilateral, presents with microphthalmos, leukocoria, and cataract, all of which are present in this case. The differentials for this include retinoblastoma, congenital cataract, Coats disease, astrocytic hamartomas, toxocariasis, ROP, and retinal dysplasias. Classically, the genetic syndromes that may include PFV are Norrie disease, trisomy 13, and Walker-Wahlberg syndrome. The most important takeaway point from this is that differentiation from retinoblastoma is critical, as management strategies differ significantly. In this case, absence of calcification on B-scan and presence of a vascular stalk on Doppler confirms our diagnosis of PHPV. The challenges that are expected in management of this patient include surgical intervention, and prognosis is guarded due to microphthalmos, corneal degeneration, and development of amblyopia. Post-operative complications like glaucoma, RD, and phthisis bulbi may also occur. In conclusion, I would like to tell you that this case underscores the complexity of diagnosing and managing PHPV in neonates. The clinical triad of microphthalmos, leukocoria, and cataract should prompt careful evaluation, as these can overlap with retinoblastoma. Early B-scan, ultrasonography with color Doppler plays a pivotal role in confirming the diagnosis. Management of PHPV remains challenging, particularly when compounded by structural anomalies like entropion and microphthalmos, all of which limit the visual prognosis. Surgical intervention and timely referral is necessary. Thank you.
Dr. Bharat?
Yeah.
Any questions,
Sir,
sir?
any questions?
Thank you, ma'am. Thank you. So next is Dr. Anamika Chaudhary is there. Dr. Anamika Chaudhary. So Dr. Babita Verma. Dr. Babita Verma is also not there.
Dr. Karuparthi Vasavi. Dr. Karuparthi Vasavi? No?
So many absentees.
Not here.
Dr. Deepti.
So we
Dr.
have the
Deepti is also not
keynote
there.
address by Dr. Deepti. And
Dr. Nisha Yadav.
Dr. Nisha Yadav.
My goodness.
So should we conclude the session now?
Yes, yes. All the speakers kindly come on the Achha, you are
there.
Okay, okay.
Dr. Nisha Yadav. Yes, please.
Your
please.
name?
Nisha Yadav.
Okay, okay. Please go ahead.
She is Dr.
Nisha Yadav, last paper, sir.
Okay.
Keynote address.
Keynote address, sir. Okay.
Good afternoon all.
This is non-competitive.
This was a
Non-competitive.
study done to compare active dioptic therapy versus part-time occlusion in cases of anisometropic amblyopia.
There are no conflict of interest to declare on these slides. Binocular perceptual learning approaches, often referred to as binocular or dioptic treatment, it involves splitting of visual stimulus elements between both the eyes. Dioptic games give binocular stimulation that rebalances the contrast between the two eyes, where the amblyoptic eye elements are presented at a higher contrast and the non-amblyoptic eye elements at a lower contrast to overcome intraocular suppression and enable simultaneous perception. This further improves visual acuity and sometimes binocularity and stereo acuity. This was a prospective randomized interventional study done at Dr. Rajendra Prasad Center for Ophthalmic Science, AIIMS, to compare the visual outcome of artificial intelligence integrated active dioptic therapy versus a standard monocular treatment approach, that is occlusion. Patients willing for this study were included in the study, which involved patients between the age group of 5 to 16 years, mild to moderate cases of anisometropic amblyopia, and who had ready availability of laptop, tablet at home for daily access, and those who were treatment naive except for the use of spectacles. After the patients were selected, randomization was done. After the patients included, randomization was done and two groups were created. The first group received dioptic therapy for 1 hour per day for 6 months, and the second group received occlusion therapy for 2 to 6 hours per day for 6 months. Follow-up was done at 6 weeks, 3 months and 6 months to assess for best corrected visual acuity for distance and near, binocularity using Paganini's striated glasses, contrast vision using Pelly-Robson chart, stereo acuity both distant and near, and the secondary aim of the study was to check the compliance in both the groups. We concluded at the end of 6 months that the age and demographic profile in both the groups were comparable. The best corrected visual acuity in both the groups improved from baseline to 6 months after the end of the intervention, although it was statistically non-significant when compared between both the groups. The near vision also improved in both the groups from baseline with p-value 0.2 to 6 months, although intergroup p-value was not significant. The contrast sensitivity, as you can see in the dioptic group, it improved from 1.3 to 1.6, which with a significant p-value, and in the occlusion group also it improved with a significant p-value, but between both the groups it was better in the dioptic group at the end of 6 months. Coming to the binocularity, which was tested using Paganini's test. Initially, when we started at baseline, it was almost 13.33% of patients with binocular vision in the dioptic group, which improved to almost 100% at the end of 6 months. Whereas in the occlusion group, we started with 10% of patients and it landed up to 80% gaining binocularity at the end of 6 months. And it was definitely better in the dioptic group at the end of 6 months. Distance stereo acuity and near stereo acuity both improved in both the groups, but intergroup it was better in the dioptic group with a p-value significant, as you can all see in the graphs. The secondary aim of the study was to see the compliance between both the groups, and we concluded that out of the 30 children in both the groups, 28 out of 30 in the dioptic group were compliant for playing the video game, which was assessed by monitoring their scoreboard and seeing their online progress periodically. As you can see in the picture, we just used to log in with their credentials and we used to have a look at how the child is performing. This dark blue boxes represent that the child is doing the exercise for 1 hour per day continuously every day, and whenever it is a blank or whenever it is a light color, that means the exercises has not been done properly, and we used to enforce the compliance by calling the patient, by enforcing compliance through parents. Whereas 22 out of 30 children in the occlusion group were compliant for patching, which was assessed by asking question to parents and observation at home. Compliance was reinforced again in the patching group by regular parental counseling and motivation. To conclude, the best corrected visual acuity and near vision improved with both the interventions and was comparable at the end of 6 months. Stereo acuity, contrast sensitivity and binocularity were all improved in both interventions. However, statistically significantly better improvement was seen with dioptic therapy at the end of 6 months. The secondary aim of compliance was better in the dioptic group due to regular monitoring of the scoreboard and more engaging games which enrolled the children further to do it, and regular enforcement of compliance is required in both the groups. Hence, dioptic therapy is a good alternative in terms of binocular vision and quality of vision. Thank you.
So excellent study this. So now coming to the, if we talk about vision as a wholesome phenomena, so it's beyond the logmar and the Snellens. I hope you agree with me. So now coming to the shape perception, the contour, the hyperacuity. So by any means you could have compared those things in these two groups?
So the contrast sensitivity was definitely compared, but as you said, the hyperacuity was not compared.
Okay.
Whether the child was able to perceive more sharp images after the intervention ended.
Thank you. Yeah.
Does the type of amblyopia affect the results?
Yes, yes. As we have done a review of literature when we initially started this, so many previous studies have been done in past, which since this was only including the anisometropic amblyopia and that to mild to moderate cases, we had landed up with a good result. But since all the previous studies involved heterozygous group of patients, both involving mixed amblyopia, strabismic and anisometropic, though those resulted, the results were not as good as we have received.
So any difference between the myopic amblyopia versus the hypermetropic amblyopia? Means does it improve more rapidly in the myopic amblyopia groups?
Sir, to be very frank, we got many patients when compared were myopic rather than hyperopic. So definitely at the end of 6 months, we saw that the myopic patients were improving greatly, mild to moderate cases.
And does these strabismic amblyopic patient, the degree of squint, does it decreases after the therapy little bit?
So we excluded those. It was not a heterozygous.
No, I'm asking about your experience. Forget about this study.
Sir, if it is yes, I have seen like after the study was over, we started giving it on a regular basis at our center. So if it was a mild grade of strabismus, so it definitely improved in the
Yes,
initial
it
stage.
improves.
Yeah, in the initial stages, in the growing age of the child.
Thank
So
you.
what instrument did you use for dioptic therapy?
Sir, it was a software, artificial intelligence-based software named QRC.
So the child would practice at home daily?
Sorry.
The child would practice at home
Yeah,
daily?
it was an online software which was initially the child was called first, the parents and the child was explained about it and regular follow-ups was done. They could do it sitting at home comfortably. They did not come to the center every time.
So in cases with mixed amblyopia with strabismus also, did you recommend this therapy after aligning the eyes? Or they were also excluded? So with mixed amblyopia, with children with having squint also, is it useful for therapy after the squint is corrected?
Sir, after the squint surgery, sir,
Yeah.
not done many cases, not enrolled. But like before surgery, if it was a mild grade of squint, like maybe 15 degree of exo or ESO, so those children definitely improved.
I request all the judges as well as the speakers to kindly come on the dais for a group photograph.
Thank you.
Yeah, please join us. Sir, आइए सर.